We can start.
All right. Hello, everyone. Welcome. Welcome to today's session. Today is session 7 of Oxygen Therapy and Critical Care, the case-based series. We're going to be talking about defining ARDS with Dr. Rachael, as usual, and with her is Dr. Eunice, and Dr. Kano will be joining us in a moment. So I will hand it over to Dr. Rachael to start us out.
Thank you, Sarah. Good evening, everyone. I'd like to welcome you to session 7 of the Oxygen and Therapy Critical Care series. So today we'll be talking about defining ARDS. So as we go through the session, in case you have a question, you can either raise your hand or indicate it in the chat box. And you could also, some sessions we have questions. So should you have any questions, we request that you respond them on the chat box, and we shall then respond accordingly. So it will be an interactive session. And with me, I have Dr. Ngatia, who is a consultant working working at Tigoni. So I want to welcome everyone to today's session, and we will start. Okay. So we have Mr. T, a 46-year-old man who presents with hypoxemia and respiratory distress. So in this part 7, we want to understand what ARDS is and how it presents and how we can be able to manage it in our facilities. So our practice change objectives is to define respiratory failure, list the types of respiratory failure, define hypoxemia using the pulse oximeter, define hypoxemia using the arterial BGA, list the 4 criteria for definition of ARDS, apply the Kigali modification to diagnose ARDS. This we don't use here, but we usually use the Berlin. Describe mild, moderate, and severe ARDS. Describe the pathophysiology that occurs in ARDS. List the principles of lung protective ventilation. Understand the parameters on a mechanical ventilator. Which parameters on a mechanical ventilator are adjusted for oxygenation. Understand which parameters on the mechanical ventilator are adjusted for CO2 elimination. Apply appropriate interventions known to improve oxygenation in ARDS. And the other one is what? Sorry, let me just move my cursor. Apply appropriate interventions known to improve outcomes in ARDS. So today's session is a bit detailed and comprehensive, but we'll try and make it as simple as possible so that by the end of it all, everyone has an idea of how to diagnose ARDS and how to manage it. So in part 6, we learned about Mr. T, a 46-year-old man who presented with hypoxemia and respiratory distress. Unfortunately, Mr. T was found to be positive for SARS and COVID-2 virus, and his clinical course progressed to respiratory failure, requiring ICU admission, intubation, and mechanical ventilation. His vital signs and mechanical ventilator settings are as follows. So you have a heart rate of 102, BP is 97/51, respiratory rate is 35, temperature is 37.5, SpO2 is 90%. Could go down. So on the mechanical ventilation settings, he's on assist control. AC means assist control, volume mode, so it's on volume control. FiO2 is at 100%, the respiratory rate is 35, tidal volume is 400, PIP is 14, and PIP, which is peak inspiratory pressure, is at 40. So on the respiratory physiology and failure, so the first thing is we want to understand, why do we breathe? What is the essence of breathing? We all know that every time we're breathing, we want to breathe in oxygen, and after that we expire CO2. CO2 is dangerous for our bodies. So by breathing in, which is usually through negative pressures that are exerted on the chest cavity, we let in air come in, and then on expiration, which is usually a passive process, CO2 is exhaled and it goes to the environment. So by breathing in oxygen, we want to now have if your lungs are fully functional and you have no issues even with your cardiovascular system, the oxygen now is then carried and taken to the rest of the tissues where we have now both aerobic aerobic metabolism occurring, and in case there's no enough oxygen, now you have anaerobic metabolism which occurs. So the aim of breathing in is to have your oxygen, which will enhance aerobic respiration and it occurs in the mitochondrial level. And then when there's no oxygen, you have now anaerobic occurring. So there's this diagram which now explains the whole cellular respiration to understand what is the essence of having oxygen. And when you don't have oxygen, what is broken down during anaerobic respiration. So this we can share it later on, but that was just the breakdown on the importance of having oxygen coming in and CO2 getting out. Can go down. Just go down, yeah. So which one of the following statements about respiratory failure is incorrect? So you have A, respiratory failure is a failure of gas exchange, either oxygenation or carbon dioxide by elimination. You have B, respiratory failure can be acute or chronic. Respiratory failure is a syndrome rather than a disease. Respiratory failure usually resolves on its own. Patients in resp failure have tachypnea, hypoxemia, and hypercapnia. So we're going to carry a poll on this, and I can give a second to people answering this. Maybe Sarah can conduct the poll for people to be able to answer.
Is not working at the moment, so how about our answers in the chat?
Oh, okay. So I can give a second or so for people to answer it on the chat. I can see some people have answered. Joyce Mutuko says D, Caleb says D. So we are asking on which one is incorrect. So A is true, it's respiratory failure is failure of gas exchange, either oxygenation or carbon dioxide elimination. It can be either acute or chronic, that's true. It's a syndrome rather than a disease. I don't know what people feel about this. Usually resolves on its own. It doesn't usually resolve on its own. You might need interventions. Then respiratory failure may have tachypnea, hypoxemia, and hypercapnia. E is true. D is the one that is false. It doesn't usually resolve on its own. You need interventions. Either you decide to give oxygen, or you can through non-rebreather masks or nasal prongs, or you can use it through mechanical ventilation. It is a syndrome rather than a disease is true. So it could go down, we could continue. List the types of respiratory failure. There are usually 4 types of respiratory failure. I'll just go through them in the interest of time. So you have type 1, which is hypoxemic, whereby you have partial pressures of oxygen being less than 50 millimeters of mercury. So at that point, your patient is hypoxemic and has low amount of oxygen entering the tissues. And this can be seen in patients who have acute pulmonary edema or patients who have acute lung injury. It could be patients like in ARDS where they have acute lung injury. And type 2 is whereby you have now increased CO2 in the patient. You have PCO2, partial pressures of carbon dioxide, being more than 50 millimeters of mercury. So in this one, you're looking at the levels of CO2. And in these patients, it can happen maybe in patients who are asthmatic or patients who have COPD, long-standing COPD, whereby they're retaining a lot of CO2 in their system. Then there's type 3, which is perioperative, which occurs in the scenario of during the operative period. It could be post-op, and the patient has probably not is not fully awake, maybe because the muscle relaxants are not fully reversed, and they tend to be retaining CO2, or even are not able to oxygenate adequately. The levels of oxygen in their systems are low. So it occurs in the perioperative period. Then you have type 4, which can occur when the patient is in shock, and usually occurs secondary to cardiovascular instability, whereby there's the issues of perfusion, and the patient clearly has low BPs and not able to perfuse, and when they're not able to perfuse, hence they're not able to take up oxygen molecules to the rest of the tissues. So you end up having some sort of respiratory failure. So there are 4 types: type 1, type 2, type 3, and type 4. So in this case, which type of respiratory failure does Mr. T have? Maybe we could go back to the case, just in case anyone had forgotten what it was about. So we have Mr. T, who is positive with SARS-CoV-2, and is now diagnosed, and his clinical course progressed to respiratory failure requiring ICU admission, intubation, and ventilation. So what we have here, we have him having a heart rate of 102. We have BPs 97/51. Respiratory rate is high, is 35. SpO2 is 90%. And then on the mechanical ventilation settings, he's on FiO2 of 100%. And he has, what they have set is a respiratory rate of 35 and the tidal volume of 400 and PEEP of 14. So what do you think? What kind of failure is he having? Is it type 1, type 2, type 3, type 4? Could answer in the chat box. Someone could try it out. Anybody? Joyce Mutuku, maybe I can pick up someone so that we don't hang in too long. Joyce, could you give it a try?
I guess it's type 3.
Why would you say that?
Because it's still saturating at 90%, and is having is been given an FiO2 of 100% and intubated. So okay, basically that's my argument, but I'm not so sure.
Okay, anyone else? Okay, let me just explain this case. This patient has COVID, and COVID, so the COVID has an issue, causes lung injury. This lung injury can then affect the respiratory function, and it's impaired. So this is a patient who presents with hypoxemia. So he presented in the previous part 6. There, I can't remember the exact SpO2s at that point, but they were low. So it's a patient who had low SpO2s, and now this patient has worsened, and now he's in respiratory failure. So because of his worsening of respiratory failure, now his mechanical ventilation settings are 100%, meaning that this patient is getting 100% oxygen and yet is saturating at SpO2 of 90%. So it's a patient who has hypoxemia. There is acute lung injury in this patient. Therefore, the lung is not being able to get enough oxygen, and we're not able to achieve SpO2s that are above 90, despite giving 100% oxygen. So this is a type of type 1. Type 4 is, someone has typed type 4. Type 4 is a patient who is in shock. He's not really in shock. His BPs are not that bad. So it's not a patient I can say is in shock. Type 3 is in the setting of post-op period or the perioperative period. And it could be due to many factors influencing it when you're intra-op or during post-op. Maybe the reversal, what I had said, the muscle relaxant has not been adequately reversed, so you're not having good respiratory effort. So here he's suffering from type 1. So we'll go to the next section of hypoxemia. I'll invite Dr. Ngatia to coordinate it. Welcome, Eunice.
Hello. Can you hear me?
Yes, we can hear you. You can go ahead.
Okay. So the bedside ICU nurse. So we're going to go through the hypoxemia part. So the bedside ICU nurse calls you and states that Mr. T's saturations has dropped to 88%. So this is already a patient who is intubated, and our levels have dropped to 88%. So for the first part, let's scroll down. How is hypoxemia defined using pulse oximeter? There you are. So as you've seen, as you've been going through this series, hypoxemia definitely means that you're actually not saturating adequately. And so you have various mechanisms that will show that you're not saturating as you should be. For this patient, what we're saying the patient has a saturation of 88%. That is already hypoxemia. And we are going to see this through the pulse oximeter. The question is, how do we see it through pulse oximeter? So SpO2 of less than 90% will be considered in essence hypoxemia. And there are various, let's see. So patients who have oxygen levels below 90% will need to be started on oxygen. And depending on how low the oxygen levels are, you will decide the appropriate tool to start oxygen supplementation. As you'll note, some patients will definitely need a higher baseline, higher than 90, for you to actually call them hypoxemic. These are patients like patients who are pregnant. You do not want them to have saturations lower than maybe 92%. Yeah, so you want their target to be 92 to 95%. Patients who have multi-organ failure or look like they're in shock or altered mental status, these are patients who their target will not necessarily be 90. You want them to have a higher SpO2. So their SpO2 you want most of the time to range above 94%. So at any point where you see the saturations are dropping below 90 or in a more or less stable patient, but now a patient with altered mental status below 94, you need to intervene. Pregnant women, you need to intervene at 92%. Okay. So we'll send this resource to you, to the inbox, to the chat box. Maybe you can go back. So the next question is, how is hypoxemia defined using arterial blood gas analysis? So we are asking, how is hypoxemia defined using arterial blood gas analysis? So arterial blood gas analysis is, most of it, we'll call it the BGA. So a BGA is a sample that you will, I'm hoping that most of you have been able to do a BGA or come across one. So BGA is a sample that you will obtain. It can either be arterial or it can be venous. And most of the time we like an arterial sample. And then the sample is run through the machine. And there are basic parameters that will come up in a BGA machine. And that is what will be able to tell us how the patient is saturating. There are things like, so the first thing you will notice in a BGA machine is the pH. So a pH will ever tell you if the patient is acidic or in terms of, is the patient having an acid-base imbalance. So is either the patient tipping towards acidosis or alkalosis. Then the other parameter you'll be able to tell is the partial pressure of oxygen. So the partial pressure of oxygen should be above 75. Then we have the partial pressure of carbon dioxide. So this can show you if a patient is retaining carbon dioxide, or they're, in other terms, like when you're trying to get rid of carbon dioxide, you want to see what are the values. So normally it's between 35 to 45 millimeters of mercury. Then you also have the bicarbonate. Bicarbonate, depending on most labs, so let's say it will range between 22 to 30. And then base excess is a calculated relative excess or deficit of a base in the arterial blood. Then you'll have your saturations, which is like our SpO2 now. So using these parameters in a BGA, you'll be able to tell how a patient is, if the patient is hypoxemic or not. The easiest measure will be like when you look at the partial pressure of oxygen. If it is lower than 75%, you can tell that the patient is hypoxemic. And also the saturations at the bottom, the SpO2, which will be like our SpO2, that can also give an indication of hypoxemia. In type 2, as Dr. Rachael has explained, the partial pressure of carbon dioxide, you will find that it is elevated. So that is another way of seeing, or even differentiating between type 1 and type 2 respiratory failure. So we'll send this to your chat box, and you'll be able to go through it in details. Maybe let's go back to. So now we are going to go to another session. We want to go to the main topic today. We wanted to define ARDS. So there's a quick question. What does ARDS stand for? Maybe in the chat box, you'll be able to put up and say, what does it stand for? There are a few choices there. Maybe you can, all the choices are available, the 4 of them. Just let's do a quick poll and then we get back. What does ARDS stand for?
Eunice, the poll is not working.
In the chat box.
Yeah, maybe put it in the chat box.
Yeah, put it in the chat box. Then we can do a quick one. What does ARDS stand for in the 4 definitions that have been given there, in the 4 choices there? Okay, I can see someone has written D. Thank you. Seeing everyone has written D. D stands for acute respiratory distress syndrome, which is correct. So, but initially, we used to call it adult respiratory distress syndrome, or I think it also used to be something like hyaline. Can't remember the other, hyaline something. So, but now the definition was refined, and even from this, the abbreviation standing for acute respiratory distress syndrome, it already depicts for you what to expect in the disease. So even in the next part of the question, it says, maybe you can scroll up. It says, list the 4 components outlined in the Berlin definition of ARDS. So in the Berlin definition, from the word itself, we can actually pick out a few things. The acute, the presentation of the patient has to be acute. Acute meaning the presentation is less than a week. So that is one of the Berlin definition, that the patient has presented with the symptoms in less than a week. So it is an acute illness. Maybe you would want to, do you want to put some other definitions in? What else do you think from the definition is in the Berlin definition of ARDS? Maybe someone will put it in the chat box. I've already mentioned one, it's acute. So what do you think are the 4 components of ARDS? Just look at the name itself. It can give you some clue of what the definition is. Anyone? Okay. So in view of time, and unless someone has answered, okay, no one has given a response. So there are 4 components in the Berlin definition. And first, we've said it is an acute onset, less than 1 week. Then the second one is you're going to find bilateral opacities on chest X-rays and on CT scan. So you can scroll up, okay. Bilateral opacities must be present on a chest X-ray or a CT, and these opacities must not be fully explained by pleural effusions, lobar collapse, lung collapse, or pulmonary nodules. Then the other part of the definition is that the respiratory failure must not fully be explained by cardiac failure or fluid overload. So you need to ensure that this patient is not in respiratory, is not in cardiac failure, or has an overload of fluid. So that is also your other qualifying factor of the patient qualifying to be called that they have ARDS. Then the 4th one is that there is moderate to severe impairment of oxygenation that must be present. So the patient, so we'll calculate something called the PaO2 FO2 ratio, and this will be able to categorize the patient. So the PaO2, which is the partial pressure of oxygen, is something that we are going to get from the BGA, as I had alluded to. So this is in the BGA. And then the FiO2 is the amount of oxygen you're giving to the patient at that particular point. So this will help us when we calculate this. We are going to determine what is the severity of the ARDS, and this will also determine maybe even the prognosis of the patient. So we do something called the partial pressure of oxygen to the FiO2. So in mild ARDS, you're going to get a value between less than 300, but it is more than 200. So in essence, it's between 300 to 200. In moderate disease, you're going to get values between 200 and 100. And in severe ARDS, the ratio is going to be below 100 millimeters of mercury. So we'll go back to our question and we'll be able to calculate this and see where we are at with Mr. T. So calculate the PF ratio. If Mr. T has an arterial partial pressure of oxygen to 60, equals to 60, and his mechanical ventilator is set to, deliver 80% of oxygen, what is his PF ratio? I'll just allow you to just calculate so that you can be able to know, just even at a glance, how we measure this. So I'll kindly ask you to participate in the chat box. Just give me the figure. What do you think his PF ratio is? P being the partial pressure of oxygen, and F being the FiO2 that the patient is getting. Kindly put your answers in the chat box. Let's see. Someone has written 133. Anyone else? We have a partial pressure of 60, and our FiO2 is 80%. And of note is when you're doing when you're dividing the FiO2, you're going to put it as a fraction. So if it is 80%, it will be 0.8. Okay. So anyone else wants to try? I've only seen one answer.
There's someone who's talked about 75, yeah.
Good. I've seen two. Okay, I've seen 75. So so that you can be able to calculate, the 75 is correct. So how we have come to this answer of 75 is, we're saying the partial pressure of oxygen is 60. So it is 60 divided by the FiO2. We've said it's 80%, which becomes 0.8. So 60 divided by 0.8, you'll get 75. So that is the PF ratio of Mr. T. So determine if Mr. T has mild, moderate, or severe ARDS. From what we have described earlier and the values I had given you, what do you think Mr. T has? Does he have mild, moderate, or severe ARDS? Let's do a quick one in the chat box. With a PF ratio of 75, do you think it's mild? Is it moderate? Is it severe? Thank you. I can see Caleb has written something. Anyone else? PF ratio of 75. I'll give you another minute. Okay, I'll go with Caleb's answer, which is true. Mr. T has severe ARDS. So we said mild ARDS is a value less than 300, but greater than 200. So it's between 300 to 200. Moderate is a value less than 200, but greater than 100. So in essence, between 200 and 100. And severe is less than 100 millimeters of mercury. That is when you call that severe ARDS. And Mr. T has 75. So that means he has severe ARDS. So the last part, maybe you can go back. Yes. In a setting where you do not have a BGA, can ARDS be diagnosed when arterial BGA is not available? So there's a resource there, and the answer is yes. In most settings, to be honest, we do not have a BGA machine. So we can be able to use the easiest thing that we have. Whatever we have used to actually determine the patient has hypoxemia, which is our SpO2, can be used in essence to be able to calculate for us the PF ratio. So instead of the partial pressure of oxygen that you get when you do the BGA, we are going to substitute that with the SpO2. So it will be the SpO2 divided by the fraction of inspired oxygen, which is the FiO2. So you'll do SpO2 divided by FiO2. From our reference, you'll notice that they said it's easy to miss out patients with mild ARDS due to this, but it's actually it's more accurate in patients with moderate and severe disease to be able to pick up ARDS using the SpO2 FiO2 ratio. So don't be discouraged if you're in a facility where there is no BGA. You can always use the SpO2 to be able to help you calculate and to give a point of reference to see if the patient has ARDS. So we can go back to the So I'll take you through this part also, the pathophysiology. So in ARDS, we're saying it's an acute respiratory distress syndrome. So it is a syndrome. You will get respiratory distress. So in essence, when you do histopathology, like they have shown that there are very early changes that occur in the histopathology. You will see diffuse alveolar damage when you do histology, in essence, when you do a biopsy. So you'll see diffuse alveolar damage. And it has, in essence, 3 stages in which we follow the early exudate stage. Early exudate in 7 to 10 days. So in the first 7 to 10 days, you will find that there is a lot of interstitial edema, there is a lot of swelling, and then there is a lot of acute on chronic inflammation. and type 2 cell hyperplasia and hyaline formation. So this is quote unquote a storm. It's more or less a cytokine, that there's a lot of inflammation going on within the alveoli. So the alveoli, they already have some edema, and there is a lot of inflammation that is going on. And type 2 cells, everything is like you're trying to defend. And so in essence, that is what you're going to see in the first 7 to 10 days. Then the second stage is called the fibroproliferative stage. So in this stage, we'll send you the resources for this. So in this stage, it occurs ideally after the 10th day, after the 7th to 10th day. There is no definitive period when it exactly ends. It's around 2 to 3 weeks. So in this stage, you're going to see the edema will start to wear off, so that you'll have some sort of resolution of pulmonary edema, and then you will start seeing early deposition of collagen in this patient. And if patients do not recover in this stage, they go to the next stage, which is the fibrotic stage. In the fibrotic stage, as we've seen earlier, there will be deposition of collagen. So there will be more deposition, and you will start getting, when you look at the normal lung architecture, it will be ruined, and there will be fibrosis, and there will be cyst formation. And this can range from mild to severe. And depending on how you progress between mild and severe, it will also show what will be your prognosis. What is the likelihood of you coming out of the ventilator? So these are the things that, even when you're dealing with a patient with ARDS, you have to keep in mind, so that you try to prevent the patient tipping over to the final stage, which is the fibrotic stage. And it is really hard to get the patient off the ventilator when they go to the extreme end of severe fibrosis. So there are few things, even as we will do the management, just keep in mind what to do to help the patient recover faster, so that they don't go down the path of this, the 3 known pathophysiology. Go down. Okay. So you want to play the video? Okay. So the next session is on treating ARDS, and I think Dr. Rachael is ready to take us through this stage. And yeah, thank you.
Okay, thank you, Eunice, for the interactive session. So in the next stage, you're going to talk about mechanical ventilation, because once you diagnose these patients who have ARDS, the next thing that you want to do is to plan for mechanical ventilation, because you now want to synchronize their ventilation with what you're going to set on the machine, because most of the lung could be 50% that is fibrotic, and you have less lung that is now available for oxygenation. So the goals of treatment are very, you need to be careful on how you want to treat these patients, because you need to understand what are your goals of treatment when you want to ventilate this patient, bearing in mind that depending on what stage that ARDS is, most of it could be fibrotic. Most of the lung could be fibrotic. So you want to do lung protective strategies. So to go down, we need to understand which mode are we going to put this patient on. Are we going to put this patient on pressure support, or are you going to put them on volume control mode? So to understand what you're going to talk about, so here we want to define and discuss the goals for each of the following parameters of mechanical ventilation. So in ARDS, when you're treating it, the tidal volume that you want to set a lower tidal volume compared to the tidal volume that you give a normal patient, which is usually 6 to 8 mLs per kg. So in ARDS patients, you want to do 4 to 6 mL per kg because you're trying to protect the little lung that is left of this patient that is functional and that is available for gaseous exchange, to avoid now more atelectasis or even barotrauma or volutrauma. Too much volume into that small little lung that is available can now be detrimental to the patient. So you want to have a low tidal volume of 4 to 6 mL per kg. You can even go as low as 3, depending on how severe, whether the patient, how severe the ARDS, once you've calculated the PF ratios. So that is the aim of understanding what tidal volume to put. When it comes to the FiO2, you want to understand that remember, oxygen is a drug. So if you keep these patients on 100% oxygen for too long, you'll now have issues of, you'll have oxygen toxicity that is eventually going to affect the lung tissue. So having a high FiO2 for too long could also be not beneficial to this patient, but even causing more harm. So in such patients, you don't want to have your aim of getting 100% SpO2 may be impossible because you have little lung that is being involved in gaseous exchange. So if you get SpO2s of 85%, it's still fine. So you now taper down your FiO2 depending on the SpO2 that you want to achieve in such a patient. Then when it comes to plateau pressure, what is plateau pressure? Plateau pressure is the pressure that is applied by the mechanical ventilator to the small airways and the alveoli. So this plateau pressure is usually measured at the end of, most of the time it's measured at the end of inspiration, whereby now the patient now has, at the end of that inspiration, there's usually an inspiratory hold, which could be about 0.4 to 1 seconds. So this plateau pressure helps to measure the pressure that is available at the alveolar level and the small airways. So understanding how high the pressure is will help you understand, are these alveoli fully blocked, or is there too much pressure getting into the alveoli that could be harmful to the patient? So having a lower plateau pressure could be beneficial as well. PEEP is peak and expiratory pressure. What is the aim of PEEP? The aim of PEEP is to help improve in oxygenation. How does it do this? It does this by trying to keep the alveoli open at the end of expiration, because it's a pressure that is exerted at the end of expiration. So you're trying to recruit more alveoli so that you can have oxygenation occurring, and you have now improved oxygenation and CO2 is expired. Remember, in ARDS, you have atelectasis. You have a lot of atelectasis that could be ongoing. And also these patients, because of the positioning in ICU, they also have the dependent atelectasis. So this PEEP tries to open the alveoli at the end of expiration so that it can recruit more alveoli available for oxygenation. And at the end of the day, you're improving oxygen, the amount of oxygen that is going to get into the patients and the rest of the organs. The driving pressure is the amount of pressure that you want to put to drive a complete breath. And then now when it comes to the peak inspiratory pressure, this is the pressure that you're going to set to enhance or to improve or to propagate an inspiratory breath, so that now you can be able to achieve the tidal volume that you have set for this patient, and have a complete tidal volume at the end of each inspiratory cycle. I hope that is clear. If there's anyone who has a question before we go to the next one. This ventilation goals are usually a headache when someone is trying to set them in ICU and you wonder what is happening. So these are the goals of management. One, you want to have a low tidal volume because you don't want to cause volutrauma in these patients. Remember, they have already, much of their lung is gone. Two, you want to have high PEEP, peak and the expiratory pressures. And then the other key thing is now you measure your SpO2s, and then you now determine how high you want your FiO2 to go. Having an SpO2 of 85% to 90% is acceptable for patients who have ARDS. So we can continue. So paralysis, why do we paralyze? Remember, some of these patients could be trying to breathe on their own, and then now you'll have something called ventilator asynchrony. So to avoid that whole ventilator asynchrony and then eventually the patient gets tired, you want to paralyze this patient and have them fully sedated in ICU, so that at the end of the treatment period, you're able now to be able to recruit the alveoli adequately, and the ventilation is achieved, and you have CO2 being exhaled and oxygen getting in, and eventually the lung heals. So paralysis is important to avoid that asynchrony or ventilator asynchrony when you set the patient on the ventilator. So of note is you need to paralyze. If you decide that, if you make the decision of paralyzing the patient, also make the decision of sedating, because you cannot paralyze the patient without having adequate sedation of this patient. Otherwise, this patient will just basically be aware in ICU, but they are paralyzed and they cannot be able to communicate. So paralyzing is important to avoid, the importance of it is to avoid ventilator asynchrony, and to ensure that, to help in ventilation and enhance and make sure that all alveoli, or as much as you can get, are recruited. On the other hand, paralysis could be dangerous, because prolonged paralysis, you're going to have acquired weaknesses, you're going to have myopathy, you might eventually get nerve injuries, and also because this patient is paralyzed for too long, you might get pressure sores, and also you might also get DVT. So having treatment goals on how long you should paralyze this patient is important. And then also giving every morning or even every fortnight, it's important to give them like sedation breaks and paralysis breaks, so that you can reassess this patient to see, are we improving or not, or where are we? Our goals of treatment changing day by day? Because ideally that's the only way you can be able to monitor these patients, by giving them, they call them sedation breaks in ICU, so that you can reassess and see how we are doing. So avoid prolonged paralysis in the ICU because of myopathy, and also pressure sores and nerve injuries that could occur. Could go down. So these are just references to show on all those things that I've talked about. We can go down. So fluid management. Should we aim for liberal or conservative fluid strategies? A dry lung is a happy lung in ARDS. So you want to be as conservative as possible, because you don't now to have issues of pulmonary edema, which will now be another headache to manage in the ICU. So be as conservative as possible when you're treating ARDS patients, when you're giving them fluid regimens. You don't have to do the 3 liters per in every 24 hours. You can do 1.5 to 2 liters, because you want the lung totally dry, because it's a lung that is sick and is unable to handle itself. You already have inflammation, you have exudates coming in, the lung is fibrotic. So by having too much a high fluid regimens could also be an issue when you're trying to resolve the ARDS. Could go on. So there's something we call prone positioning, as according to the picture. So the patient is basically lying on their tummy. This prone positioning is important because it helps, it frees the lung. The rib cage is now not pressing on the lung, so it's freeing the lung, and all those dependent places that had atelectasis are now able to try and open up and be able to ventilate. So it helps in recruiting and also improving oxygenation. During this COVID period, of course, it was a bit difficult, especially if you had patients who are really overweight, so you needed a lot of manpower. It's a hard thing to do, but at the end of the day, it has proven to be important and of help in treating patients with ARDS, because it helps to clear even the secretions and also frees the lung. And once that lung is freed from the rib cage, you have more expansion of the lung and you have more recruitment of alveoli, and hence oxygenation is improved. So when should it be used? Should be used in patients you suspect have ARDS in the ICU. It's something that you plan, so you can decide to do it every 4 hourly, every 6 hourly, depending on how that patient is. So the earlier you start prone positioning in this patient, the better. So you need a lot of manpower to be able to prone that patient in the ICU. So when should it be used? I've said in which patients, and how is it done in the ICU. This is just a picture, a video of how it is done. I don't know how long it is. Maybe we could try and see. It's 5 minutes. Okay, we'll share this, then you could have a look at it. could have a look at it at your own time. We could continue. So there's something that's called pulmonary vasodilators. In the West, they tried using them. Okay, it's not a common practice, or I've not seen this being done in our setup, whereby we use now the vasodilators to help improve ARDS, or to try and improve the effects of ARDS on the patients that you have. So they use nitric oxide and inhaled prostacyclin, and apparently it improves the mortality in ARDS. This I have not tried it myself, but literature says that there's some that say yes, it can improve, and there are others that say there's no added advantage. So this is, I guess, in our setup, we've not tried it, so I'll not get into too much into it, but just know that pulmonary vasodilators could also be of help in some situations. So case conclusion. So Mr. T has been in the ICU under your care for 10 days. So he's been in the ICU for 10 days. After he was placed on mechanical ventilation and dexamethasone. He received non-neuromuscular blocking agents and underwent intermittent prone positioning according to the protocol for 5 days. He was also placed on inhaled prostacyclin. His fluid balance was kept negative using intermittent diuretic medications. On day 8, his oxygenation began to improve. His FiO2 and PEEP requirements decreased, and he remained hemodynamically stable. On day 10, you're now considering sedation weaning and further weaning of the mechanical ventilation, and soon a spontaneous breathing trial is in hopes of extubation. So this is just to show that after all those interventions were made, now there's at least improved outcome, and the outcome of the patient is better and the patient is improving. So remember the goals of treatment, as I had said earlier: low tidal volumes, high PEEP, proning position, and monitor your FiO2 through using your SpO2. Monitor your SpO2 and then you determine what your FiO2 would be. So practice change, we're coming to the end. Practice change objectives. So the aim of this is to define respiratory failure, which we've done. List the types of respiratory failure. Define hypoxemia using the pulse oximeter. Define hypoxemia using arterial blood gas analysis. List the 4 key criteria for definition of ARDS. Apply the Kigali modification to diagnose ARDS. Describe mild, moderate, and severe ARDS. Describe the pathophysiology that occurs in ARDS. List the principles of lung protective ventilation. Understand which parameters on the mechanical ventilator are adjusted for oxygenation. Understand which parameters on mechanical ventilator are adjusted for CO2 elimination. Apply appropriate interventions known to improve oxygenation in ARDS patients, and apply appropriate interventions known to improve outcomes in ARDS. So these are the practice change objectives that you should now have by the end of this session. If you want to lift yourself up, lift up someone else. That is a quote by Washington. So we've come to the end of this session. I want to give a second to questions, or even a minute. Could anyone be having a question? Just, you can unmute yourself. Anyone who wants some clarification? Or anyone who'd want to talk about something that they have experienced in their setup on management of ARDS?
Maybe I can add something. On one of the objectives, we've seen CO2 elimination. Maybe we what parameter is adjusted for CO2 elimination? Maybe you can see that at times you do you increase the respiratory rate at times to be able to, we call it washing off of the CO2. At times there's that question. In case there's any other question, Dr. Rachael is here to answer.
There seems to be no other question. So we want to come to an end to this session 7 on definition of ARDS and management of ARDS. I want to give a special thanks to everyone who attended this session for your participation and for even creating time to be part of us. We really appreciate it. Thank you also, Dr. Ngatia, for being part of the team to help in at least give refresher. This is a refresher course. It's not really, I believe everyone has gone through this to help at least improve the understanding of ARDS. Also want to thank Sarah through Assist International and also Stanford Medicine. Thank you for putting these sessions together. We really appreciate it. So our next sessions will be in January, but this time around we'll not have it the first Friday of January, which I think falls around the 4th. So we're going to have it on the next, just to confirm.
The 14th.
Yeah, we're going to have it on the 14th after everyone has settled from the holidays.
Bienvenidos a todos a la terapia de oxígeno y cuidados.
Sorry. So we're going to have it on the 14th, and it's going to be our 8th session, and we're going to talk about high flow nasal cannula and non-invasive ventilation. So here we're going to try and elaborate more on the CPAPs and the BiPAP ventilation during the non-invasive ventilation basically, and how to go about it. So I want to encourage everyone to join us at that point. And without anything else, I think we can call the session to come to an end. I don't know if Sarah has anything to say before we close up.
No, that's great. Thank you so much, Dr. Rachael. And just to add, thank you to Project ECHO for funding this program and making it possible. And a reminder that if you have questions about the material between sessions, we do welcome you to use the WhatsApp group to ask questions and solicit solutions for if you're encountering any challenges. So thank you so much for joining, and we hope to see you in the new year.
All right, thank you. Merry Christmas to everyone and Happy New Year. Okay, bye-bye.
Bye-bye.